Good evening, everyone. I'm Megan Coleman. It is part 2 of our exclusive look at a remarkable heart procedure that gives patients a new heart valve without any surgery. Tensions build as doctors revive a patient after they purposely stopped the beating of his heart during that procedure, a moment that is sure to leave you on the edge of your seat. Our exclusive inside look at this cutting-edge new heart procedure continues tonight as Matt joins us from live inside the operating room at St. Joseph's Hospital. Matt?
Well, Megan, earlier on NBC3 News at 5:30, we took you inside the operating room, and when we left, the cardiac team had just stopped the patient's heart from beating. Just at that moment, that's when they need to deploy that valve. Let's head back into the OR and show us how they made it up to that moment.
For a percutaneous left femoral TAVR procedure with a number 29 sapien valve.
The TAVR team gets to work. 1 minute into the procedure, cardiologist Dr. Ron Caputo raises concern about the patient's low heart rate.
Why is this heart rate in the 30s?
The incision is made in the left groin area. Passing the catheter can get bumpy. Calcification gets in the way in the 86-year-old patient.
It's very crunchy artery.
The team prepares the way to introduce the new valve. Again, concern about the low pulse.
Why is his heart rate in the 30s when we started? He's in flutter, so he might need a pacer before he goes home, you know.
The Edwards sapien valve is rinsed, then crimped onto the delivery catheter. It must be small enough to pass through the aorta before being positioned and inflated. Several sets of eyes interpret the angiography.
This is the skirt, and
this is proximal toward the ventricle.
yes. Yep, the leaflets are here.
Okay, all right, so we're okay. It's good to check that.
Have lights off again, please.
They test the position with dye. The patient's cardiac rhythm continues to struggle.
Now let me just get this up here, reorient it, and load the valve.
Dr. Caputo stands with cardiac surgeon Dr. Randy Green. Tension builds. It's time to speed up the heart rate, forcing it to stop for the instant needed to deploy the valve.
All right, let's do it. You all ready? Your lungs are still down?
Yep.
Pacer on. Okay. Inject. Go up.
No.
Take that. Hammer it now. 1, 2, 3, 4, 5. Down. Pacer off, please. Okay. Pacer off, please. Yeah, let's shock him, please.
Everybody clear. Charge. Go ahead, hit it.
Yep. Get ready with the pacer, please.
60.
Pace it 60.
Don't plug it in yet. Yeah.
You want to?
Yes.
Yeah, pace it now at 60.
60.
He's coming back.
Okay. Sergeant, he may need a little neo.
Let me get this out of the valve. Huh?
The gravity of the moment passes. A transesophageal echo indicates the valve is properly seated. The new leaflets have taken the place of the old.
He's calming down nicely.
Yeah.
All right, good.
Describe for me that moment then, leading up to that. Where are you in the procedure and kind of what happened and how'd you get out of it?
We want everything to be very still, so there's no motion. We actually have to pace his heart so fast it stops. And so for that period of time, there's no cardiac output, there's no blood flow. And, although it's really only a matter of a few seconds, for us it seems like about 10 years while that's happening.
So what did you do today to handle that and get everything back on course?
Well, the first issue is recognizing that the patient has a rhythm that's inconsistent with life. Cardiovert the patient into a rhythm that perfuses and resuscitate him with medication. As you saw, our anesthesiologist plays a major role in that, having the right medicines drawn up, responding quickly. The longer that period lasts, obviously, the greater the risk to the patient.
Seems to me that was an instance where we talked about the team idea.
All right.
The team ends up being,
You got it.
makes all the sense in the world.
Absolutely,
Right? Having both of your skills and everybody else in the room, would you agree that that's one of those
Absolutely. It's
moments
always
where-
good to have somebody, to run things by, and, two ideas is better than one. And, sometimes Randy comes up with something great, sometimes I do, but yeah, definitely a team approach is helpful.
Yeah. And joining me now here live is interventional cardiologist Dr. Ron Caputo, and we are talking in the piece about the team concept. This is really a big change in the way cardiologists and cardiac surgeons work side by side, but it's working for you very well, isn't it?
It's really working well. Took a little getting used to, as you can imagine. A lot of personalities in the room, but I think it's been one of the really nice aspects of getting this program going together. I think we appreciate what each other really does during the course of a day, and I think we complement each other.
What are some of the risks? You know, we showed a positive outcome here, but there are a lot of risks for the patient here, aren't there?
There are a lot of risks. These patients are, in general, elderly and have multiple other medical problems, so they're at risk anyway. And the things we worry the most about really are vascular problems from the site of entry. There can be some bleeding and so forth. The artery might not heal exactly the way you want it to. The other risk that we worry about is stroke. There's a small chance that a patient could have a stroke. Heart attack, less so. And then just sort of all the other things that might go along with the person through anesthesia and so forth.
With regard to TAVR as a procedure and a technique, where is it going from here? Will there be further developments that will make this better and more useful for other purposes?
Yeah, I think that we've already seen some really exciting developments. The equipment's getting better. We're getting some adjunctive equipment to help us with the holes and the arteries and so forth. Just better devices, easier to deliver. I think that eventually we will be able to apply this technique and technology to an even broader patient base. More patients might be eligible for it.
Dr. Caputo, thanks very much. Fascinating to be in the hybrid operating room. Dr. Randy Green, the cardiac surgeon of the piece, was not able to be here tonight. Otherwise, we would have been talking with both sides of this cardiac team. Megan, a fascinating view inside the operating room live here from St. Joseph's Hospital.
Clearly a very capable team, Matt, and our thanks to them for that incredible access inside the OR.